All right, let's dive right in. We're going to talk about a critical and honestly often overlooked part of emergency medicine, thermal trauma. And no, I'm not just talking about burns. We're going way deeper, into the body's internal battle for survival when its own thermostat just completely goes haywire.
So let me ask you something. Picture this. You're in the middle of a major trauma situation. You're running the checklist, right? You've got the bleeding under control, you're on top of the airway. But what if the biggest, sneakiest danger isn't the wound you can see, but something you can only measure with a simple thermometer?
That's exactly what we're going to do today. We're going to explore this hidden battle for thermal control that's going on in every single trauma case. And listen, if you're gearing up for your finals or you're already working in acute care, getting a grip on this stuff isn't just good to know. It is absolutely life-saving.
Okay, so to really get what goes wrong, we've got to start with what right even looks like. Let's talk about the body's own amazing built-in climate control system.
I mean, just think about it for a second. Your body is an absolute master of homeostasis. It is working 24/7 to keep your internal temperature locked into this tiny, super safe range. And this isn't about feeling comfy, right? This is a precision-tuned biological thermostat that makes sure everything, everything, from your enzymes to your brain is firing on all cylinders.
And then bam, this happens. A severe trauma, a bad car crash, a major fall, a deep wound. It's like taking a sledgehammer to that delicate thermostat. And just like that, the body's ability to control its own temperature is shattered, and the patient is thrown into a whole new kind of immediate, silent danger.
So let's kick things off with the first big bad guy in this story, the cold. And let me be clear, in the world of trauma, cold is an absolute killer. Okay, so by the book, hypothermia is a core temp below 35 degrees Celsius, or 95 Fahrenheit. But here's the thing you have to burn into your brain for a trauma patient. Any drop in temperature is a huge red flag. Why? Because it kicks off something called the lethal triad of trauma. It's a vicious cycle. See, when the body gets cold, the blood just doesn't clot right. That's coagulopathy. That, of course, means more bleeding and shock, which leads to a buildup of acid in the body. That's acidosis. And these three things, the hypothermia, the coagulopathy, and the acidosis, they just feed on each other, spinning the patient down into this deadly spiral.
This table here, using the Swiss staging system, it just lays out that downward spiral perfectly. Just follow the progression. At stage 1, mild hypothermia, the body is still putting up a fight. It's shivering like crazy, trying to generate heat. But look what happens at stage 2, the moderate stage. The shivering stops. That right there is a huge ominous sign. It means the body is giving up. It's losing the battle. And from that point on, it is a terrifyingly fast slide into unconsciousness. And then, below 24 degrees, the patient can look for all the world like they're already gone.
So you might be asking, why is this so incredibly common in trauma patients? Well, it's basically a perfect storm. First, you've got exposure, right? The patient is out in the environment, at the scene of the accident. Then you have massive fluid and blood loss, which is like draining the radiator of a car. It just robs the body of its heat. And the real kicker? If there's a head injury, the brain's own command center for temperature control can get knocked completely offline. It's a recipe for a catastrophic temperature drop.
All right, let's totally flip the script now. Because that thermostat, it can break in the complete opposite direction, leading to a life-threatening spike in temperature. Yeah, we're talking about heat stroke.
Now, it's really important to know there are two main flavors of this. First, you've got your classic heat stroke. Think of an elderly person during a brutal heat wave. Their body's cooling system just can't keep up with the heat outside. But then there's exertional heat stroke. This is totally different. This is your young, super fit athlete on a hot day. Their body is generating a crazy amount of heat from the exercise, so much that it just completely overwhelms their own cooling mechanisms. And make no mistake, both are absolute emergencies.
So how do you spot it? The diagnosis really hangs on this classic clinical triad. Number 1, major league hyperthermia. We are talking a core body temp rocketing past 40 degrees Celsius. Number 2, and this is the big one, altered mental status. We're not just talking about feeling a little dizzy. This is full-on confusion, delirium, maybe even seizures. And number 3, the story. You have to have a history of exposure to extreme heat or intense exercise. You get those 3 things together, bingo, you're looking at heat stroke. Okay, so we've laid out the threats, right? The cold and the heat. Now, for the important part, how do we fight back? Let's head into the emergency room and see what the interventions look like.
So how do doctors fight back against these silent killers in the trauma bay? Well, the approach has to be aggressive, and it has to be immediate. With both hypothermia and hyperthermia, the clock is ticking loudly. any delay means you're risking irreversible cell damage, organ failure, and ultimately death.
For hypothermia, the goal is aggressive, controlled rewarming. Now, when your patient is cold, the mission seems simple, right? Get them warm. But that word, controlled, is absolutely crucial, because if you rewarm someone too fast, you can actually trigger a really dangerous complication called rewarming shock. So you have to be super systematic about it.
And this is the playbook, right here. You start with the simple stuff, the passive things. Get that wet clothing off immediately, pile on the warm blankets. Then you escalate to active external rewarming. But where you really make a difference is with active internal rewarming. We're talking about infusing warm IV fluids straight into their veins and giving them warm, humidified oxygen. You're basically heating the patient's core from the inside out. It's incredibly effective.
Now, for heat stroke, it's the exact opposite goal. But the urgency is, if anything, even higher: rapid, immediate cooling. The mission is to get that core temperature down, and fast. Seriously, every single minute that a patient spends above 40 degrees Celsius, the risk of permanent brain damage just skyrockets.
So how do you do it? The gold standard technique is evaporative cooling. It's actually pretty simple. You get all their clothes off to maximize skin exposure. Then you start misting their skin with lukewarm water, not freezing cold. And you get fans blowing on them to make that water evaporate as fast as possible. While that's happening, you're also putting ice packs on the big heat exchange areas, the neck, the groin, the armpits, and you can push cool, again, not ice cold, IV fluids. Put it all together and you have a really powerful way to bring that core temp down quickly.
Okay, so we've covered the internal thermostat, but that's only one part of the story. Thermal trauma also includes direct attacks on the body from the outside in. Let's talk about burns, fire, and chemicals.
Right. So beyond just managing that internal thermostat, trauma teams also have to deal with these direct thermal assaults on the body. It's like you're fighting a war on two fronts. You're trying to fix the central heating while the walls are literally on fire. And the range of these external injuries, it's just incredibly wide.
I mean, just look at this list. You've got inhalation burns, which you see in fires and enclosed spaces. They can cause the airway to swell shut in minutes. It's terrifying. Then there are chemical burns from acids or alkalis. With those, the chemical will just keep chewing through tissue until you get it off, so decontamination is everything. And then you have these really nasty ones like petroleum burns, where the stuff is so sticky and hard to remove that the burning just keeps going. Each one of these is a unique emergency that needs a specific, immediate response.
So, if there's one thing to take away from all this, it's that in the trauma bay, a thermometer can be just as crucial as a scalpel. Seriously. Managing a major trauma is so much more than just fixing the holes you can see. That silent battle against the cold or the heat is every bit as critical, which means a core temperature reading is one of the most important vital signs you can get.
Look, at the end of the day, just recognizing the danger is the first, most important step. So whether you're sitting in an exam hall or you find yourself at the scene of an accident, just remembering this, that a simple thermometer can be as important as a scalpel, that knowledge could be the difference between life and death. All this information comes straight from the Advanced Trauma Life Support Course Manual, which is basically the Bible for anyone in this field. So I'll just leave you with this question. After hearing all this, will you ever look at a thermometer the same way again?